So today's topic is anxiety disorder management part. So we had learned about normal fear versus pathological anxiety, cognitive, biological, and behavioral signs and symptoms of anxiety disorders, and etiology on the basis of biopsychosocial model and classification according to ICD-10. Example are agoraphobia with or without panic disorders, social phobia, specific phobia, and generalized anxiety disorder. And we learned about the differential diagnosis. So management basically has three parts. The first is lab investigation. The second is pharmacologic treatment and non-pharmacologic treatment. In lab workup, a targeted workup is required, and if possible, tests should be selected to rule out or rule in the specific other diagnosis, which may be the differential diagnosis for anxiety symptoms. And here is a we had discussed about the long list of medical disorder which can mimic as anxiety disorder. In all the new patients, routine tests to be considered, including complete blood count, electrolytes, fasting glucose, HbA1c, kidney function test, liver function test, thyroid function test, and urinalysis. Occasionally, additional studies may be indicated to rule out pheochromocytoma via urinary catecholamines, seizure disorder by EEG, cardiac arrhythmia by ECG or Holter monitoring, and pulmonary disease uh, can be ruled out by pulse oximetry, arterial blood gases, and X-ray. Brain imaging may be useful in ruling out demyelinating disorders, tumor, stroke, or hydrocephalus. In pharmacological treatment, the available drugs of classes of drugs are tricyclic antidepressants known as TCAs, selective serotonin reuptake inhibitor known as SSRI, selective norepinephrine reuptake inhibitor SNRI, benzodiazepines, beta blocker, buspirone, and low dose of antipsychotics like flupentazole. The commoner TCAs are which we use nowadays are amitriptyline and clomipramine. In SSRI, the widely available drugs are escitalopram, fluoxetine, fluvoxamine, paroxetine, and sertraline. Can be used in SNRIs. Duloxetine, atomoxetine, desvenlafaxine, and venlafaxine are available. In benzodiazepine, the most common drug used for anxiety is clonazepam and oxazepam. Lorazepam can also be used, but it is reserved for sedating effect for sleep disturbance. Diazepam somewhat not used nowadays, and chlordiazic oxide is reserved for alcohol withdrawal syndromes. Beta blockers like propranolol, metoprolol, atenolol can cut down the peripheral symptoms of anxiety like increased heart rate, sweating, tremulousness can be controlled by these. Now look at the mechanism. Uh, the tricyclic antidepressants block the transporter site for norepinephrine and serotonin both, while SSRI selectively blocks the serotonin reuptake at site 1, which you can see in the green circle. And MAO inhibitors enzyme inhibit the enzyme in the presynapse in mitochondrion. In the red circle, you can see the autoreceptors are there, which signals the presynapse that there is more availability of serotonin while a patient on treatment, and it can send the feedback to reduce the production and release. So few novel antidepressants like vortioxetine take care of these uh, biofeedback of autoreceptors. The novel antidepressants acts both on the site 1 and site 2. Benzodiazepines are actually interacting with GABA receptors to open the channel, and there is depolarization of the neuron. And GABA is known for its inhibitory effect, so calming down effect is there. And benzodiazepine are known to cause immediate relieving effect on anxiety, while the TCS and SSRI and other drugs take more time to act upon to the fullest. The doses of these drugs are, and for TCS, amitriptyline is 50 to 150 milligram, clomipramine is from 100 to 200, SSRIs, escitalopram, starting dose is 10 and can go up to 20 or 30. Fluoxetine is 20 to 80, fluvoxamine 50 to 300, paroxetine is 10 to 20, and likewise. In SNRI, the commoner drug is duloxetine, which can be given up to 40 to 60 milligram, and desvenlafaxine from 50 to 100. So the commoner benzodiazepine which are being used is clonazepam, and can be given in the two divided doses from zero point 0.5 to 2 milligrams per day. Beta blocker, you all know the dose of propranolol is 40 to 400. Buspirone is 20 to 30, and flupentazole is 1 milligram in divided doses two times a day. Now, while we are prescribing these drugs, we should also know about the side effects of these drugs. So the side effects should be known to you and can be taken care of. The cardiac side effects for TCS can be tachycardia, QTC prolongation, flat T wave, and depressed ST. Autonomic effects are orthostatic hypotension. Neurologic side effects are tremors, myoclonic twitches, paresthesias, peroneal palsy, ataxia. Allergic side effects can be agranulocytosis, leukocytosis, leukopenia, and eosinophilia. Hepatic are self-limiting rise in enzymes and fulminant acute hepatitis. Other may be sedation, weight gain, sexual problems like delayed ejaculation, and SIADH. The side effects of SSRIs are SSRIs has less severe or less prominent side effects than TCS because it is selectively inhibits the reuptake of serotonin, and in exception, paroxetine can have anticholinergic side effects more than that of other drugs like dry mouth, constipation, blurred vision, urinary retention, and delirium. So, if the person comes with the uh, problem of urinary retention, you can think of anticholinergic side effects of SSRI or TCS. Autonomic effects are same, orthostatic hypotension. Neurologic other side effects will be anxiety. It may increase anxiety in the initial phase of treatment. Insomnia, sedation, vivid dreams can occur. Bruxism, restless leg syndrome, nocturnal myoclonus, sweating, and yawning without feeling sleepy, emotional blunting, EPSCs, and lower seizure threshold are neurological side effects. Hematologics are functional impairment of platelet aggregation, endocrinal or hypoprolactinemia. The person can have serotonin syndrome, which is a fatal syndrome due to TC or SSRI, and this condition should be treated in ICUs. The symptoms are agitation, insomnia, confusion, rapid heart rate, high BP, dilated pupil, twitching, rigidity, and can have irregular heartbeats, seizure, and unconsciousness. Other side effects are weight gain, sexual problem, and SIADH are similar to PCS. Now, the side effects of benzodiazepine is mild cognitive deficits. The person can have lower decision-making capacity, so these drugs should be avoided in persons such as who are uh, working upon heavy machinery or are drivers or driving vehicles. So driving and working upon heavy machinery should be avoided, or the drugs should be avoided while drinking. Anterograde amnesia can occur, so the drugs should be avoided who are in uh, the job of students who have to learn the things. The person can have anterograde amnesia and have difficulty for in concentrations. Others are aggression, hepatotoxicity, respiratory depression. Withdrawal seizure can occur in case of benzodiazepine dependence, ataxia, hallucinosis, and it can stimulate the appetite. So while you are going to treat the patient with anxiety disorder, some general principles to be considered. Uh, for example, for drug selection, efficacy and adverse effect should be kept in mind. Patient variables like age, sex, and if the person is having comorbid other physical illness or psychiatric illness should be kept in mind. And in some medical disorder, uh, these disorder may be responsible for the anxiety symptoms itself. So taking care of these comorbidities. The duration of treatment, the person asks how long do I need to take the medication. The answer uh, is depend on multiple variables like nature of disorder, what kind of disorder the person is having, the duration of symptoms, if the genetic loading is there, and the extent to which the patient tolerates the side effect of drug and benefits from the medication. So risk benefit ratio should be uh, the considered point in defining duration of treatment. So treatment is usually defined and is conceptually broken down into initial therapeutic trial, the continuation phase, and the maintenance phase. The other point to be considered or have in your mind is the treatment does not provide absolute protection against relapse, and these treatment are not curative of the illness most of the time. And continuation therapy is required for relapse prevention. And in addition to early onset, history of multiple past episodes, severity, and length of current episode would make longer treatment duration or even indefinite treatment may be appropriate in some conditions. This is the course of anxiety disorder. Uh, just look upon the graph. There is low anxiety and it progresses to disorder like panic disorder or others. And in acute phase of treatment, you have given the drug and there is a response. And after response, there is a period of remission. And after the period of remission, the patient is in the recovery phase. And if the patient is having uh, the symptoms of disorder again, the patient can be classified as recurrence of uh, that disorder. Now, now coming to the non-psychopharmacological treatment, uh, other than drugs, what we can use is cognitive behavior therapy, systematic desensitization, implosion, applied relaxation, respiratory exercises, and virtual reality therapy. Because in the etiology, there are three components, biopsychosocial. Uh, the bio part can be taken care of by the drugs, and the cognitive part and behavioral part of the disorder can be managed by non-psychopharmacological method. So we will discuss about the behavior therapy, cognitive behavior therapy. There are two components, cognition and behavior. So in this cycle, vicious cycle, thought creates a feeling, and the feeling creates a behavior, and behavior reinforces the thought. So we will look upon how this is happening and how this works in the disorder. So CBT techniques are the techniques to identify negative thoughts. Negative thoughts means distorted thought or the thought uh, which is not in the context of the situation. And it is important to learn how thoughts, feeling, and situation can contribute to maladaptive behaviors. So, in this cognitive behavior therapy, you have to generate a list of possible solutions, evaluating the strength and weakness of each possible solution, choosing a solution to implement, like practicing new skills to combat the disorder. And it is important to start practicing new skills that can then be put into use in real world situation. So first of all, you have to set the goal. A therapist can help in goal setting skill by teaching how to identify your goal and distinguish between short and long term goal and set smart goals which are specific, measurable, attainable, relevant, and time based, and then implement the solution. And this therapy can target either cognition, behavior, or both. So this is the vicious cycle for panic attacks. What happens in panic attacks on the basis of CBT model? There is a panic attack occurs, and that attack is misinterpreted as heart attack or MI. Then the person acquires a behavior of hypervigilance or anticipatory anxiety of having another attack. And this behavior increases the anxiety and fear, and again a panic attack occurs, and the cycle goes on. So here, misinterpretation as heart attack is the cognitive part, and hypervigilance and hypervigilance is the behavior, and anticipatory anxiety of having another attack is also part of cognition. So one have to correct this cognition and behavior in the person. And for agoraphobia, there is a repeated situational panic attacks, and it is misinterpreted as it occurs in open situation. This is the cognitive part. The attack occurs in open situation or crowded places from where easy escape is not possible. The person started avoiding such situations. The avoidance is the behavior, which further increase the anxiety, and the situation is repeated. In social phobia, the cognitive part is it is misinterpreted as if the person is being judged and being considered stupid, or the person himself thinks that I will definitely make a mistake while presented to a social situation. So this is the cognitive part, and the behavioral part is avoiding social situations. In specific phobia, the specific situation is misinterpreted as a dangerous situation, and avoiding these specific situations occurs as a behavioral part in specific phobias. There are few key benefits of CBT which has to be pointed out, that it allows you to engage in healthier thinking pattern by becoming aware of the negative uh, connotation and often unrealistic thought that dampen the feeling and the mood in a negative way. It is an effective short-term treatment option and found effective for a wide variety of maladaptive behaviors. It is often more affordable. It is effective online as well as face-to-face. And specifically, this is useful who do not require psychotropic medication. Some patients do not demand that I don't want medication, so the therapies can be used in such situations. The next one is systematic desensitization. It's a therapy It's actually a type of behavioral therapy used to treat anxiety disorders. There are three parts of this systematic desensitization. The first is to learn the way to relax your muscles. The next part is to make a list of fear and rank them based on how intense your fear are, and to start exposing yourself to the to that feared situation in a gradual manner. So the first part is learning the relaxation technique. These relaxation techniques can be deep muscle relaxation, and the relaxation techniques are generally are of three types. First is autogenic relaxation, and second is progressive muscle relaxation and visualization. In autogenic relaxation, you repeat the words, phrase, or suggestion in your mind that creates a feeling of relaxation. And in PMR, one have to learn slowly, tense, and relax each muscle group. And one normally starts from toes and goes upwards in systematic manner. And the third one is visualization. After learning the technique of relaxation, one have to create an anxiety hierarchy, and the the list is created on the scale of 1 to 10, and at the first level, level 10 fear, which cause the highest amount of anxiety that can be imagined, and in the last, the list level 1 fear, which causes the least amount of anxiety, and in between, rank the other feared situation or objects. So hierarchy is made. Now in the third step, working up through the fear scale through exposure. Now one have to expose to those fear one by one, and acclimatize to the non-anxious state. And till the non-anxious state is attained for one fear, do not go for the another feared situation. This can be done in vitro or in vivo. In vitro, the patient imagines being exposed to the object of fear in the mind. In vivo, the patient is actually exposed to the fear. For example, the person is having fear of traveling in lift. Person can be taken to the lift along with you, and while the reassuring to the patient, the person can be exposed the to the situation of lifts. The third type is known as virtual reality exposure therapy. In this technique, a VR box is used, so the person is actually exposed to the real life situation in a computer generated environment. So for systematic desensitization for arachnophobia is discussed here. Arachnophobia is fear of spiders. At the start, the therapist might simply discuss. You can discuss about the spiders, then gradually introduce the pictures of the spiders, and further next step could be watching a spider on video, and then further handling the spider in actual situation. This will reduce the anxiety being exposed to the feared object. And you should keep in mind that the person should not be overwhelmed by the exposure. If the exposure is going in a wrong way, the person will feel more anxious and drop out from the therapy. This thing should be kept in mind. Implosion is based on opposite rationale of the systematic desensitization. That is, it is more effective to begin at the top of hierarchy rather than the bottom, and that rapid extension might take place. And these therapies are implied, but systematic desensitization are more comfortable and fruitful for the patient rather than the implosion therapy, in which the person is immediately exposed to the feared situation and left in that situation till the anxiety relieves. The respiratory exercises can be helpful in relieving anxiety, and Usually, the people with anxiety, they tend to take rapid and shallow breath that we had discussed in the previous lecture. The communication between amygdala and parabrachial nucleus causes the shallow and rapid breathing. And this type of breathing is called thoracic or chest breathing. And causes an this thoracic breathing causes an upset in oxygen and carbon dioxide levels in body, and resulting in increased heart rate, dizziness, muscular tension, or other physical sensations. And in the shallow breathing, blood is not being properly oxygenated, and it also may signal a stress response that contributes to anxiety and panic attack physiologically. So there are various type of respiratory exercise. Is simple breathing, and in which one have to inhale slowly and exhale slowly, and keep a concentration on the air going into the lungs, which is basically a yogic exercise. Other exercises are deep breathing exercise, alternate nostril breathing, box breathing, 4-7-8 breathing, lines breathing, mindful breathing, pursed lip breathing, and resonance breathing. So, in short, the box breathing is not someone is breathing in a box or in a bag, but the box breathing is named because of this picture came out uh, while it was imagined that the person inhales and hold for a few seconds and exhale after holding the few seconds, and then the person also hold the breath and then inhale again. So this makes it a box like picture. That's why it is called as box breathing. Again, in 4-8-7 breathing, it is also based on the holding of the process. uh, Breathing in your nose for 4 seconds and hold for 5 seconds and breathe out from mouth for 8 seconds. This is the name is 4-7-8 is given on the basis of the time period which is given in this process. Loins breathing is a form of pranayama, a breathing exercise from the yogic tradition, and you can have an idea by this picture how it is performed. Uh, it involves forceful exhalation through the mouth with the tongue extended and stretched down towards the chin. So this is lines breathing. Pursed lip breathing, in which one have to sit with your back straight or lie down, relax your shoulder as much as possible. Inhale through your nose for 2 seconds, feeling the air move into your abdomen. Try to fill your abdomen with air instead of just your lungs. Purse your lips like you are blowing on hot food and then breathe out slowly. So there is nothing special. The lips are pursed and the breathing is the inhalation and exhalation process is done accordingly. And this is resonance breathing. In resonance frequency breathing is a way of breathing. It is slow, relaxed, diaphragmatic breathing at around 3-7 breaths per minute. That has a regulating effect on the autonomic nervous system and other key body systems such as circulatory system. So, resonance means it is a frequency of 3 to 7 breaths per minute. So, called as resonance. So this is the picture of virtual reality therapy. In this picture, one is wearing the VR box and experiencing spider as if in the real and in the vicinity of the patient, and trying to relieve the anxiety by gradual exposure. So now conclusion is that there are lab investigations are required in management of the person. Classification of drugs, we know that SSRI, TCAs, benzodiazepine, beta blockers are there. We have learnt about the mechanism of actions and doses and side effects of the drugs, and about the general principles of psychopharmacology. And apart from medicine, non-pharmacologic management is also available, like cognitive behavior therapy, systematic desensitization, implosion, applied relaxation, respiratory exercise, and virtual reality therapy. Thanks for patient listening.